Okay, I think we're gonna get started.
Yep.
Yeah, it was like Carlos, am I doing the intros? How are you going to get you on stage?
There we go. One of the many ways.
Yeah.
All right, guys. Thank you so much for coming back. Great. And I think a very interesting, very insightful presentations. Thank you to Dr. Birch for presenting last. So to return back to our presentations, I have the true honor of presenting one of the best doctors that I know, and one of the best people that I know. She was a fellow at UIC and has now become a irreplaceable part of our team as part of our bone marrow transplant team and one of our awesome providers who takes care of patients with multiple myeloma. She's also spearheading the CAR-T expansion program for autoimmune diseases at UIC, and so she is doing an amazing job. And so it's with great honor that I have Anna present for us today on the advances in BCMA-directed therapy for myeloma.
Thank you. Thanks, everyone. So good afternoon. Thanks for the introduction, Dr. Galvez. So yes, I'm a hematologist at UI Health, and I'm here to present the most updated advances in BCMA-directed therapies in multiple myeloma. So to get started, I have no disclosures. So as an introduction, BCMA, B-cell maturation antigen, is a key target for multiple myeloma because it's selectively expressed in malignant plasma cells. And there's been this amazing advance in different modalities of targeting BCMA. So we have CAR-T cells, T-cell engagers, antibody drug conjugates, and I walk you through the most the latest advances in all these modalities, and we're now even talking about trispecifics as well. So starting with CAR-T cell therapy, the latest data, and I think this is probably one of the most important slides for the presentation. I kind of decided to just put it first. So I kind of want to, before going into the 5-year overall survival update of CARDU1, I wanted to give a little bit of a background and put this data into perspective. And this is just showing the locomotion data on your right. And this was a real-world registry data with heavily pretreated patients, median 4 lines of therapy, pre-CAR-T era, right? And at that moment, well, I think the little, is there any way we can minimize the PFS was around 4 months, or overall survival was 13.8 months pre-CAR-T era. And now with the CARDU1 5-year overall survival, you can see the difference in the Kaplan-Meier curves. Also very similar patient population, so heavily pretreated, 6 line of therapy. And the PFS is unremarkable. We kind of see a little bit of, the long tail is real. We see a little bit of flattening of the curve at the 3-year mark, which is unprecedented in myeloma. And I think the key takeaway here is that 33% of the patients at 5 years were alive and progression-free. So something unheard of, after one infusion, no maintenance therapy, so one thing and done. And the median overall survival was 60.7 months. So, compared to what we had before, definitely something groundbreaking. And some experts are not talking about this 1/3 of patients achieving a functional cure. So going a little bit more into detail, what is the difference between responders and non-responders? So patients that had a 5-year progression-free survival, the theme here is the tumor burden. So patients that were responders had lower tumor burden in their bone marrow, so less plasma cells, of 5% compared to 24% in patients that progressed within 5 years, also less soluble BCMA. So I think this highlights the importance of bridging therapy prior to CAR-T cell infusion. So definitely optimizing the disease control prior to CAR-T cell therapy seems very important in maintaining this long-term response. Another thing that I want to highlight is that in the responder, it seems that there's slow numbers, but still some patients with high risk that also had 5-year progression-free survival. So you see 7 patients and 4 patients with extramedullary disease as well. So maybe not only limited in standard risk patients, also we see a role in high risk patients. Regarding long-term safety data, reassuring, no new cases of Parkinsonism or cranial nerve palsy, so that's reassuring. 2 additional cases of SPMs, so there was a case of lung cancer and cancer, but they're all seen in long-term follow-up. So the investigators did not adjudicate this to the CAR T-cell products, which is also very reassuring. This is a little bit more like a thought-provoking correlative work done in CAR-T1. And you can see pre-infusion responders had a higher T-cell to neutrophil ratio, and they also had a higher proportion of feeder naive T-cells. So definitely the CAR T-cell product matters for long-term response. And then post-infusion, there was a higher overall effector to target ratio in patients that respond, as well as more CD4 positive T-cell with central memory phenotype. So definitely the fitness of the cells matter in the CAR T product. Now switching gears to CARTITUDE-4, this is a slide to remind ourselves about this pivotal trial that put cilta-cel as a second line. So in patients with refractory myeloma, 1 to 3 lines of treatment, line refractory, DARA naive, they compare cilta-cel versus standard of care that showed benefit in PFS and OS, and the long-awaited was a survival subgroup analysis to try to see if this efficacy was also seen in higher risk population, and it was. So cilta-cel at median follow-up of 33.6 months had favored cilta-cel over standard of care in patients with high risk cytogenetics and also with patients to 2 or more cytogenetic abnormalities. So also something very encouraging. There is still an area of improvement in CAR T-cell era, and that's extramedullary disease. So we know these patients behave very differently, very poor outcomes, and still with cilta-cel, we saw a PFS of 12.6 months versus 4 months in standard of care. So the improvement is modest, but is there anything we still need we can do better for these patients? And definitely, I think in the later slides, we will talk about maybe new strategies for these patients too. Something also interesting at ASCO was a poster where they show retrospective data from patients in Mayo Clinic, 235 relapsed refractory multiple myeloma patients who received cilta-cel, and they look at delayed toxicity. So I think 4 takeaways here. The one is that immune effector Parkinsonism was associated with elderly, like age 75 or older, and also high tumor burden. And the other important thing to highlight is that those Parkinsonism neurotoxicities long-term were also associated with the severity of CRS and the duration of CRS. So a more inflammatory profile would lead to this neurotoxicity developing. The second key takeaway, I think, is the immune effector enterocolitis. So you can see that was associated when they use alkylator as a bridging therapy. So maybe thinking twice about using alkylator as a bridging therapy, because it seemed that it could be associated to enterocolitis long term. So and then the one that was, I think, one of the most important findings was that post-infusion monitoring the absolute lymphocyte count seems important. So it seems that an ALC higher than 3,000 could predict for development of neurotoxicity, so Parkinsonism and cranial nerve palsies. So what some centers are doing right now is actually giving preemptively steroids for patients with ALC higher than 3,000 post-infusion. And, is that the trick? I think we, of course, need prospective validation for this strategy, but it's kind of showing how we're trying to manage and prevent those rare but very severe and worrisome long-term toxicity. Regarding bispecifics, I think, also something evolving, I think right now is about the combination. What can we combine bispecific with? So here I want to talk first about elranatamab. So in magnetism 3, this was presented at ASCO last year. I think the main thing to take away is that there's a de-escalation strategy in this study. So you could de-escalate from 1 week to Q2 weeks, depending on partial responder or better, and then the idea is to de-escalate to every 4 weeks. So which is very convenient for our patient population. Of course, something that could be done easily in the community as well. And the median follow-up of 33.9%, despite the de-escalation, we could see really good overall response rates around 61%, so maintained. And there was a PFS of 17.2 months. Now, the update at ASCO was the US subgroup analysis of magnetism 3. So how did the results in American patient population. So total 47 patients. We can see there were some African American included, no ethnicity reported, so we don't know how many Hispanics were included there. But despite that, 47% of them were able to de-escalate to every 2 weeks. And something to think is the overall response rate was a little bit better than in the overall group, was 66% versus 61%. But the interesting thing is that the progression-free survival was better, 27.3 months, versus, as we see in the last slide, here was 17.2. So 10-month difference in PFS in the US subgroup analysis, which I think is interesting. Not sure if that's because of patient selection bias or maybe use of IVIG, better prophylaxis, supportive care. But I think that's maybe something it's worth investigating a little bit more. Regarding safety data, comparable to safety data that we know, of course, infections are real with bispecifics, 70% any grade infections, 42.6% grade 3 or 4 infections. So this is real. And now with magnetism MM6, this was presented at ASCO. We're looking at combination of elranatamab with daratumumab. And this was in the setting of transplant-ineligible, newly diagnosed multiple myeloma. So the idea is with lenalidomide, we could enhance the T-cell activation, and then with daratumumab, to try to deplete those immune suppressive cells by ADCC. And this whole combination, the idea is to enhance the activation of myeloma cell death. So I brought here the schedule of the dosing. So elranatamab will be monthly, sub-Q. Of course, the step-up dosing initially, and the idea is Dara will be weekly in the first two cycles, then bi-weekly, and then we'll go to monthly. So something that is feasible for the patient. And so in the results that they showed, 100% of patients that were newly diagnosed multiple myeloma. And here I want to highlight the age. So median age was 75 years old, and they did include patients that were 80 years older, which in Cepheus, 80-year older patients were not included, right? The other thing was the frailty. There was 24% of patients that were frail. So a little bit more to the real world patient population that we have that is transplant ineligible, newly diagnosed multiple myeloma. Follow-up is still very short, 7.9 months. And I think probably the data is still immature, but really good overall response rate, 97.3%. Most frequent side effects, we know cytopenias, of course, infections, but it does seem that with this combination, infection rate seems pretty similar to what we got with monotherapy. But of course, something to have in mind. So this is going to lead, of course, to a phase 3 trial now that is going to compare elranatamab daratumumab to our standard of care, DRD. So I think this is really exciting. Do we have a new standard of care coming into play? I do want to say that the Maya results are pretty good anyway. DRD, we achieve a median PFS of 61.9 months with our current standard of care, which is really good. The only thing is probably there's a population of patients, high-risk patients, 2 or more high-risk cytogenetics, that could maybe favor to something else. The PFS is 24 months, so really a big gap there. So, could play a role in those patient population. But again, infection risk is higher, it seems like, with this combination. So now moving to linvoseltamab. So this is a bispecific that was approved in Europe, is a fully humanized bispecific. And some like housekeeping, characteristics is it's IV, so it's not sub-Q as we're used to here. It seems for the IV formulation that CRS onset is early, so 11 hours versus 2 days that we're used with our bispecifics, and also the duration is shorter. So the monitoring is around 24 hours, and also the step-up dosing is different as 1 week apart, day 1 and day 8 for step-up dosing. So this bispecific was combined with bortezomib, and this was the linker MM2 trial that was presented at ASCO this year. Also of note, bortezomib in Europe, they do it bi-weekly instead of weekly, so that's something else to have in mind when we're like extrapolating the data. But early data, only 24 patients, they were all triple class exposed. Triple refractory, half of them had a median follow-up of 9.3 months with the limbo dose of 200 milligrams and bortezomib. We see a good overall response rates, and infections, they are very similar to what we see. Also neuropathy, similar to what we see with bortezomib only, so not really big safety signals here. They also presented this combination with carfilzomib and with the second generation proteasome inhibitor. But in this setting, also early data, only 5.6 months of follow-up, so the data has to mature a little bit more. But I do think there's a safety signal here. The combination with the second generation does increase the risk of infection. So you can see overall 91.3 patients with infections, 53.5% with grade 3 plus infections. So it is promising, these combinations, but I think sometimes you have to kind of pause a little bit and think, what's the risk that we're putting our patients, and then, the infections are real. This is also very exciting, combination of talquetamab and teclistamab. This is not like recent data, it was already published early this year in the New England Journal of Medicine, looking at talquetamab, 0.8 milligrams per kilogram, combined with teclistamab, 3 milligrams per kilogram every other week. And in this study, I think one thing to have in mind is that they had 40% with extramedullary disease, so the patient population. They were all triple class exposed. Overall response rate at the RP2 dose was 80, and then in the group of extramedullary disease, they had a really good overall response rate of 61%. That translated in a duration of response of 18 months duration of response was 82% in extramedullary disease. So really good in this patient population that is hard to treat. Regarding safety data, now that we're combining two bispecifics, actually CRAs, most of them were grade 1, grade 2. Neutropenia was, as we expect, around 60% in grade. Regarding the GRPC5D related side effects, so taste changes, nail changes, that is really bothersome for our patients. It was a little bit less to what we see, so also very promising here. Regarding the infections, I think this combination for sure has a safety signal here for infections, really high, 86.4% any grade, and grade 3 to 4, 47%. However, I would say to note is that in this patient population, it seems that 80% receive antiviral prophylaxis, so not all the population, and only 56% receive IVIG, so maybe something that we could improve. And I think the exciting thing at EHA that was presented a couple of weeks ago was the phase 2 trial of this combination exclusively in extramedullary disease. So, bringing a new strategy for these patients that are very hard to treat. And, overall response rate was actually great, 78.9% compared to monotherapy when we're only able to achieve 43% overall response rate. So definitely, I think maybe this combination has found a niche in extramedullary disease space. And this translated to a duration of response, a median duration of response of 13.8 months. And just again, also putting this into perspective, and cross-trial comparison is limited. But for example, ide-cel median duration of response in extramedullary disease is around just 5 months. Here we have 13.8 months. So something worth considering for for this patient population. And regarding safety data, again, GPRC5D side effects a little bit higher, neutropenia also important. And here, the infection rate, I was surprised, it was not as high as we saw it in the phase 1b trial. And you do see that more patients receive antiviral prophylaxis in this cohort, more patients had IVIG. So probably, it seems like we're improving in preventing those infections. So I think, there's hope in trying to deliver a safe strategy for patients with extramedullary disease. Now, regarding emerging therapies, and before going into this part of the talk, I kind of wanted to remind ourselves, like, why do we need new emerging therapies? Why do we need to change targets or to look at other strategies? And, the challenge is there. This is karma data, challenging expansion and persistence of the T-cell product. We know mechanism of resistance of T-cell engager that we can put them, in two buckets, antigen-driven versus microenvironment-driven. And in the microenvironment-driven is just allowing this non-permissive microenvironment with high Tregs, T-cell exhaustion. So how can we overcome that? Then regarding the mutation of antigen and loss of BCMA. So yeah, biallelic loss of BCMA is rare. And now what we're seeing is possible single allele loss of BCMA associated in the other allele with mutations in the SCVF domain. So although this is what we're seeing in preclinical data, we still don't know what is the incidence of those mutations in the real world after CAR T cell. So probably a mechanism here too. So this leads us to let's improve the binding domain. And so now we're talking about D-domain BCMA CAR T cell therapy. And I brought here the two different BCMA CAR T products. So we have the SCVF domain versus the D domain, and you can see the D domain is smaller. It seems that it's also more stable. So the CAR density on the T cell surface is higher, and that potentially can increase the efficient multiple myeloma cell killing. So a more efficient CAR T cell product. And this was studied in Imagine-1, a phase 2 study that introduced anito-cell or anito-captigene autoleucel. That is this CAR T cell construct with the D domain. And those results were presented at EHA a couple of weeks ago with 117 patients, again, still short follow-up, 12.6 months, but a heavily pretreated patient population, 41% were penta-refractory. And we see amazing overall response rate, 97%, and really deep MRD results as well. Like from the MRD evaluable patient population, they achieved MRD to 10-5, 93.3% of the patients, so deep responses. And PFS 12 months was around 79.3%. So you think, I have a more effective CAR T cell construct, what about the side effects? And actually this is reassuring. CRS, most of them grade 1, grade 2, and ICANS, only 8% of the patient had ICANS, and all the cases resolved. So it seemed like a more potent and efficient CAR T cell product with manageable CRS and ICANS. Also of note to point out is that there are no delayed neurotoxicities that they could see so far in this short follow-up. So no Parkinsonism, no cranial nerve palsies, no Guillain-Barré, which is also very reassuring regarding cytopenias infection. I think it's very similar to what we have. No enterocolitis cases so far, and no cases of secondary primary malignancies with this CAR T cell product. So this is now leading to even more exciting things. Phase 3 trial now enrolling the Imagine-3. So comparing anito-cell to standard of care in earlier lines. So even patients as early as first relapse, they could now be enrolled in this clinical trial. So more exciting things to come, and maybe as another option as a second line, besides cilta-cel. And this is, I think, also very novel, the tri-specific. So this was presented at ASCO this year. So tri-specific combining, targeting BCMA, GPRC5D, and CD3. So it's got J&J 5322 early data, phase 1 results. And I think the convenience is that they're able to get to a dose of 100 milligrams every month. So tri-specific giving monthly subcutaneously. Still short numbers, 36 patients, 50% triple class refractory, and in BCMA, GPRC5D naive patients, 100% overall response rate. So really impressive. That also translated to a PFS, 12-month PFS of 95%. Regarding now safety, of course, I think importantly, and I think that's something reassures that there's less off-target effects seen in the GPRC5D space, less taste-related changes, nail-related changes that we see, and no grade 3, grade 4 events related to GPRC5D. So that's also reassuring. Not a lot of weight loss, which we see a lot with talquetamab, but it seems that it was something transient, only grade 1. So, this is the data that we have. So now, we have the tri-specific versus a combination. How are we going to choose? What are we going to, we have all these options. And of course, I think we definitely need more follow-up data, looking at MRD results, looking at long-term safety data to make a conclusion here. But I'm just was showing here the data that we have so far for the combination TAC. I think the safety signal here is the infection, but it seems that with appropriate prophylaxis and IVIG, it seems that we can overcome that. And definitely, this is I think unprecedented to see this results in extramedullary disease with the combination. So for sure, I think something that we could maybe offer in this specific patient population. So one specific is not enough. We have another one presented at ASCO, ISB 2001. This one targets BCMA, CD38, and CD3. Early, data, only part 1, phase 1. So not a lot of data, 35 patients. Glad that they included extramedullary disease patients, 34%. They also included patients that had prior exposure to CD38 and it's also refractory to CD38. So kind of seeing even being refractory to CD38, exposing them to this tri-specific, I think it will be interesting to see that. Overall, high response rate across subgroups, and even with extramedullary disease and high-risk cytogenetics, it seems that overall response rate is good. Manageable adverse events as well with this tri-specific. And in the interest of time, I did not went through all of the new BCMA updates, but I think something to have in mind is our old friend belantamab mafodotin made a comeback in combination with bortezomib, so also something to be at the lookout and reviewing. So to conclude, I think sequencing is still a main question in multiple myeloma. We have all these new important strategies, CAR T cell, trispecifics, bispecifics. I think we still need more data to decide what will be the best agent based on disease biology, what will be the best agent to sequencing based on exposure and response. And I think still we need also more data on how to best manage the toxicity, the infection, and the immunosuppression in our patient population. So thank you, and I'm happy to take any questions.
So, I'm pretty impressed. I think that when you think about cell therapy and multiple myeloma traditionally, right, you think of this kind of PFS maker, but not really this functional cure that you could show that 30% of patients in 5 years, plus an additional 22-month follow-up, right, was what you showed. So why is the field moving forward for the CAR T earlier up, because the potential curability is similar to lymphoma, or is it still
Yeah, and we saw that in CARTITUDE-4 now, is approved at second line. So definitely it seems that even at second line, it can overcome the poor prognosis of high risk cytogenetics as well. So definitely moving early lines. Now what we are always waiting is, and we have a trial looking at, can it replace transplant? So that's, something to, but we don't have any data there yet.
Thank you, great talk. Can I ask you, so based on the red nano study, the magnitudes, trying to reduce the frequency of the dosing, what would be your recommendation nowadays with bispecifics? Once patients have achieved the response, how are you planning on using them?
Yeah, I think that we do have to balance a lot the toxicity and, I think if a patient is starting to have recurrent infections or on tocilizumab having a lot of taste changes, that, the quality of life is getting impaired. Because I think in this refractory patient population, one of the things also to have in mind is their quality of life. It's great to give them very potent and efficient medications, but what if they're not able to eat, drink, or have their, favorite meal? So I think that definitely in that regard, I would probably try to de-escalate sooner. Of course, trying to make sure, that they're maintaining their response, maybe closely monitoring, but at least if they have some response already, I think I'll feel more inclined to de-escalate sooner.
And that was amazing presentation. Thank you so much. So last but not least, we have one of the most amazing fellows I've ever worked with. He's one of the second-year fellows, going to be a third year. Actually, are you third year yet? Next week. All right, week moves. Who is, I am sure, a future leader in the field of myeloid or lymphoid, his choosing. But he has done presentations with others in the past, and he's done such a phenomenal job that we wanted to re-invite him and give us a little lecture on the role of MRD testing on treatment decisions in myeloma. Thank you so much, Pierre.
Thank you, Dr. Galvez, for that kind introduction and good evening, everybody. So we're going to be talking about the role of MRD testing in treatment decisions and outcomes in multiple myeloma. This is I prepared this topic with one of my mentors as well, Dr. Sanchez. So let's start just by saying I do not have any conflicts of interest. So this is a little bit of the agenda. We're going to talk about an introduction. We're going to spend a little bit of time in biochemical relapse and progression of disease, and then the role of MRD in maintenance discontinuation. What are the implications of the loss of MRD, and what is the role of sustained MRD negativity in progression-free survival, as well as MRD-driven treatment strategies. And then we'll finish with some conclusions. So, introduction. So we know that technically, most of the patients that initially achieve a complete response eventually relapse. We know this, and this is likely reflecting some persistent disease via clonal evolution, right? So we know that we are going to be talking about two topics today, MRD progression and MRD progression or MRD resurgence, but that most of the clinical benefit is associated with MRD negativity. We have evidence that suggests that these patients that are able to achieve MRD negativity have improved outcomes in terms of PFS and overall survival. We also know that patients with MRD positivity will have similar outcomes to patients that are not able to achieve a complete response. So the trending topic in myeloma about MRD testing is going to be the treatment decisions. It has therapeutic implications. When do we escalate? When do we de-escalate? Or when do we decide to stop treatment in our patients, as Dr. Avila was saying, in terms of toxicity especially, right? So, and why is this important? Because again, even though in terms of biochemical progression, when we have this, it doesn't necessarily mean that all of our patients are going to progress or have evidence of clinical symptomatic disease. So we need to try to do better in terms of identifying what are the patients that are going to be doing or presenting with clinical relapse. On the right here, again, I'm showing by Dr. Monshi that once you're able to achieve MRD negativity, regardless of if you're a newly diagnosed patient that is transplant eligible, transplant ineligible, or if you are in the relapse refractory setting, you will have a better progression-free survival as long as you're able to achieve MRD negativity. Now, this is per IMWG 2016 response criteria. We all know this. We always try to achieve VGPR or better. We know that a stringent complete response is what we should be aiming for. But then in 2016, we also started introducing the terms of MRD, right? And when we talk MRD, we are trying to say, do I need one single value when I'm able to achieve MRD negativity, let's say at 10 to the minus 5, meaning that I was able to detect one cell out of 100,000 cells evaluated, and this could be done by either next generation flow or next generation sequencing, which is pretty much done by clonoSEQ by adaptive biotechnology, right? Or more importantly, if we were able to achieve one single value of MRD negativity, are we able to achieve a second value 1 year apart, which is known as sustained MRD negativity, which is probably going to be even better than a single measurement. So we know all of this. And then we also have imaging plus MRD negativity. We know that imaging is very important as well, either by MRI or PET scan, and this is going to be mainly important for patients that present with oligo-secretory disease or extramedullary disease. Now, again, assessment of MRD negativity, 10 to the minus 5 is what's recommended, but we know that clonoSEQ is able to do MRD at 10 to the minus 6. And we have one specific concept that was mentioned earlier, MRD negative, not in CR. This is particularly important in patients that are receiving CAR-T, where you are destroying the source of the paraproteinemias, but we know that there's going to be a delayed clearance of these paraproteins. It means that the patient is still in MRD negative, but not in CR because you are still seeing the paraprotein in the blood. So, does treating biochemical relapse improve outcomes? And here, let's see this study by Dr. Goldman-Mazur. This is a retrospective study that decided to treat patients at biochemical progression or at clinical progression. Again, clinical progression when the patient develops CRAB criteria or symptomatic disease versus biochemical progression when there is only a rise in the paraprotein, for example. We see here that the proportion of patients free from third line of therapy is going to be longer when you start treatment when there is biochemical progression in the blue line compared to those patients that develop already with symptoms, which is on the red line. And this overall survival is also going to be prolonged in those patients when you decide to treat them at biochemical progression. Again, these are only retrospective studies. Now, what are the patterns of relapse after a complete response in patients with multiple myeloma? And here I will introduce once again the term of sustained complete response. This is another retrospective analysis by Mayo Clinic of 351 patients that were able to achieve a complete response after induction. Most of them actually had some patterns of loss of complete response, and this can be either by symptomatic progression, biochemical progression, or this is defined by IMWG, right? Or simply those patients when we see a rise in the paraprotein or a rise in the free light chains, and we are like, we don't really know what to do. Is the patient progressing or not? But what's important is that all of the patients, again, that were treated at any sign on the top right, at any sign of biochemical progression, are going to have a prolonged overall survival compared to those that were treated when they develop symptoms. And on the bottom left, we're going to see that those patients also that were treated are at biochemical progression versus those that we say, no, maybe let's just observe and see what happens. Those patients treated earlier are also going to have a better overall survival. So what about MRD resurgence? Does it improve the outcomes? And here, let's focus on the role of MRD in maintenance discontinuation therapy. How many times have we questioned or our patients come to our clinic and say, hey, for how long should I be on Revlimid, right? We know that Revlimid is going to be able to achieve and sustain MRD negativity in maintenance for those that were not MRD negative before. But this is particularly special during the first year. About a quarter of patients are able to achieve MRD negativity if they were not during the first year, but it becomes less and less frequent as long as the years go on. So this is a burning question within the myeloma community, right? Because we don't know when to stop it. Is 2 or 3 years enough? Is it okay for as long as the patient is able to tolerate? We don't think sometimes that this is a medication that can have significant side effects, right? Significant impact in the quality of life because of the side effects. We also know that there is an association with secondary malignancies and moreover, the cost of the medication, right? So I think that's why this is important. Now, let's focus on this study first. This is a great study by Dr. Evangelos Terpos, where 52 patients who were able to achieve the MRD negativity, if they were able to achieve MRD negativity, there was the option to discontinue lenalidomide maintenance and be followed over time and see how they did, okay? 40 out of those 52 patients remain MRD negative at the cutoff of this study, but 12 other patients became MRD positive, right? Now, from those patients that developed MRD positivity, they were able to take Revlimid again, and only one of those patients was able to achieve MRD negativity status again, and 7 other patients, even though they are MRD positive, were able to achieve complete response again. The other 4 patients progressed. Now, this is another important study, and this is by Dr. Derman, MRD stop, where 47 patients were able to discontinue maintenance after a median follow-up of 36 months and at least 1 year of maintenance therapy. Now, important is the study that I just said used a sensitivity of 10 to the minus 5. This study used a sensitivity of 10 to the minus 6, and there was an experimental arm, or I'm sorry, an exploratory arm that was also using a sensitivity of 10 to the minus 7, okay? Now, out of those patients, the 47 patients that were able to discontinue maintenance therapy and be followed over time with serial MRD assessments, 11 patients converted. But what's important to know is that out of those patients, most of them actually had high-risk cytogenetic abnormalities, okay? And that's important, and we'll see why. The other patients, 5 of them were actually positive at a sensitivity of 10 to the minus 7, okay? At least when they were tested. The other 3 patients were positive a year before, and the other 3 patients became positive at the time where they became positive also 10 to the minus 6. Why am I saying all of this? It's because we know that the sensitivity matters as well, and the depth of the remission will matter. We know that an improvement of the sensitivity in MRD testing will be associated with an improvement in the progression-free survival. I really like this image by Dr. Derman as well, that is saying pretty much, you're given this task to find a coin in this pool, you're gonna dive into it, right? But there's gonna be certain level where you're gonna be able to reach out to, right? It doesn't necessarily mean that the coin isn't there. It may be there, it may not be there. We don't know. If you don't find it, it means that maybe there is something at a lower level that you're not able to get into. Okay, so that's why depth of remission matters. Now, and we can see it here, the Italian Forte trial and the Spanish trial, when you use a different cutoff or a different sensitivity for MRD testing, we know that we get a progression-free survival that is gonna be longer in those patients when you're able to achieve a sensitivity that is deeper, right? So what are the clinical implications of a bone marrow MRD conversion? Okay, so this is another study by Dr. Mohan from the University of Arkansas, and these patients were followed, prospectively, and after a median follow-up of 9.9 years of diagnosis, around 61% of patients have been able to maintain MRD negativity. This study is also telling us that those patients that are able to achieve a sensitivity of MRD negativity at a sensitivity of 10 to the minus 5 have a better progression-free survival. It's pretty much telling us the same. But what's important here is that the loss of MRD negativity predicted a clinical relapse at a median time of about 1 year. Now, if we see here on the left, those patients that are MRD negative, we see that most of them, 95.9%, didn't really have any evidence of clinical relapse. For those patients, however, that converted from MRD negative to positive, even though there are 27% of patients that did not have evidence of a clinical relapse, most of them didn't have any evidence, either biochemical or symptomatic relapse, okay? But then again, this is telling us something, right? That there is a percentage of patients that even though convert from MRD negative to positive, they may never have any disease progression, which is kind of similar to those patients with biochemical progression. About a quarter of those patients after 2 years are not gonna have any evidence of symptomatic disease. Which ones are those patients? That is a question. And here, once again, just showing the Kaplan-Meier curves where MRD conversion confers an inferior survival compared to those patients with sustained MRD negativity. Now, MRD dynamics matter. As I said before, it is not important to have one single value. It is important to have a sustained MRD negativity, and that's gonna translate into a better PFS and OS. Now, what is the optimal MRD-based endpoint for treatment cessation and newly diagnosed multiple myeloma? This is a study by Dr. Smith-Geary. This included patients from master trial and an institutional database from the University of Alabama in Birmingham. So this was also seeing which one is gonna be the best one that we should be using for clinical trial purposes, right? Because we know that we used to do a stringent complete response or complete response before. Then we started the single assessment MRD negativity at 10 to the minus 5, then MRD at 10 to the minus 6. As we see here in the curves, the lower it gets, it's gonna have actually better outcomes, and then sustained MRD negativity at 10 to the minus 5 and 10 to the minus 6. This study showed once again that the best endpoint for treatment cessation is gonna be sustained MRD negativity at 10 to the minus 5. What is important to notice here as well is that the progression-free survival is gonna be better in those patients that have no high-risk cytogenetic abnormalities compared to those that have 1 or 2. And we know that those that have 2 or more are the ones that do poorly. That's gonna be on the left. And the one on the right, the cumulative incidence of progression of MRD progression is also gonna be higher in those patients with 2 or more high-risk cytogenetic abnormalities. So what are the predictors of MRD resurgence and progression of disease in transplant-eligible multiple myeloma patients? This is part of the Spanish trial. We see here that MRD resurgence or progression of disease happened in 111 patients, and an MRD progression happened in 71 patients compared to a progression of disease that was not followed by MRD in about 40 patients. The predictors of unsustained MRD negativity in this study were those patients that had a higher ISS at diagnosis, a higher index of circulating tumor cells, or the longer that it takes for the patient to achieve MRD negativity. Post-induction is better, post-transplant is probably okay, post-maintenance is gonna be fine as well, but it's never gonna be as good as when you do post-induction. And we see it here in the lower bottom. Those patients that are able to achieve MRD negativity, the line in yellow, those patients able to achieve MRD negativity post-induction are the patients that are gonna have the lower probability of MRD resurgence compared to those patients in pink that are the ones that achieved MRD negativity within the first year of transplant, of post-maintenance therapy. And on the top, we can see the same, that those patients with a high index of circulating tumor cells or those patients with an ISS of 3 at diagnosis are gonna have a higher probability of MRD resurgence compared to those that do not have those. All right? So, MRD dynamics during maintenance, and this is also important. This is another study. It included patients of tourmaline MM3 and MM4, those patients that were transplant eligible and ineligible, ineligible for transplant, newly diagnosed multiple myeloma. This also showed that MRD status is dynamic, and once again, the prognostic value increased with periodic versus a single assessment. Now, this study was pretty much studying the use of exacerbate maintenance after induction, and we wanted to see what the role of maintenance is in those patients that are MRD negative versus those that are MRD positive, that are the ones that probably need it the most. We see here that the median progression-free survival is going to be 38.6 months in those patients that are MRD negative versus 33.7 months in those patients that were positive, okay? And then the median progression, And what we see here, the lines in blue and red, which are going to be the patients that are already MRD, the lines in blue and red, those patients that convert from MRD positive to negative, and those patients that are already MRD negative, there is really no benefit of adding maintenance therapy compared to those patients in green and purple, which are the ones that really need the most, which are going to be the patients that transform from MRD positive to negative. Now, I think this is also important to mention the Perseus trial, because nowadays we're no longer using triplets anymore, right? Or doublets. Now we're using the quadruplets. So the Perseus trial is important because in this post-hoc analysis, it also showed that sustained MRD negativity is probably the best endpoint that we need for our patients. And this included Dara-VRD versus VRD, followed by Dara-Len maintenance or Len maintenance. As we see here, after a median follow-up of 47 months, the 48-month progression-free survival is going to be longer in those patients treated with a quadruplet Dara-VRD compared to VRD alone. And the overall MRD negativity and CR rate is also going to be longer, as we see here on the right, in those patients treated with Dara-VRD compared to VRD alone, either at a sensitivity of 10 to the -5 or a sensitivity of 10 to the -6. This is showing pretty much the progression-free survival. When you have a sustained MRD negativity of more than 12 months on the left or more than 24 months on the right, you're also going to have a benefit in terms of progression-free survival when you use quadruplets compared to VRD, which is also very similar to the results of the ISCIA trial that used ACCREDITED versus KRD instead. Okay. So should we intervene when there is MRD resurgence? And before we move on to the prospective trials, this is a small retrospective trials with 400 multiple myeloma patients in whom, but had a special select group of 67 patients in whom a decision was made based on MRD results, mainly during maintenance. So 33 out of those 67 patients that were MRD negative, 3 of them reduced the treatment and 30 other patients decided to stop the treatment. And out of the other 34 patients that were MRD positive, 27 patients had an intensification of treatment and 7 patients were switched to a different treatment. Now, as we see here on the top, the change in therapy based on MRD, there is gonna be a benefit in the median progression-free survival. But if we see the one on the bottom left, there is not gonna be a benefit when you are already MRD negative. There is no statistically significance here, the B 0.1. On the bottom right, however, for those patients that are MRD positive and you decide to intensify the therapy or escalate therapy, you're gonna see that there is gonna be an improvement in median progression-free survival that is gonna be statistically significant. So based on this, we are gonna move on to the master trial. This is the design of the master trial. This is a prospective study. DARA-KRD followed by transplant, followed by up to 2 blocks of consolidation with DARA-KRD, and all those patients that were able to achieve 2 consecutive MRD negative values at 10 to the -5 were able to enter the MRD short period where they were observed alone. Those patients that were not able to achieve MRD negativity were moved on to maintenance Revlimid. What's important about this trial is again that among all of those 118 patients for whom MRD was evaluable, the 36-month progression-free survival was gonna be higher for those patients with no high-risk cytogenetics. This study is important because it included patients, or it was enriched with patients with high-risk cytogenetic abnormalities. And the 36-month overall survival is gonna be also longer when you do not have a high-risk cytogenetic abnormality compared to when you have 2 or more. So those are the patients that are really doing poorly, in whom we should start thinking about escalation of therapy, especially when they become MRD positive or when we are not able to achieve MRD negativity, especially now in the era of quadruplets. Now, for those patients, out of those 118, 84 were able to enter the MRD sure. As I said before, these are patients that were managed with observation alone. Again, the progression-free survival is going to be longer when there are no high-risk cytogenetic abnormalities. Same is true for overall survival. And for those with 2 or more, those are the ones that are going to be the worst outcomes. The MIDAS trial was reported a couple of weeks ago, actually, in the ASCO. This is another response-adapted strategy based on MRD. This used ACCREDITED for 6 cycle. And for those patients that were MRD either negative or positive, they were allocated into transplant arm or no transplant, especially if you were MRD negative. If you were MRD positive, you would still get transplant plus chemotherapy versus a tandem transplant. And it was aiming to determine if there was any benefit of transplant, especially when you were MRD negative. Now, this was pretty much all the patients that were enrolled. But what's important is that even though here, if we see on the top left, on the top left, let's say 73 and 76% of patients, that was a percentage of the patients that were able to achieve MRD negativity after induction. And if we see on the right, the group that says transplant and ACCREDITED, there is a small percentage of patients that was able to achieve MRD negativity after either transplant or ACCREDITED if you were MRD negativity, but the difference was not statistically significant. So that is already questioning the role of transplant in this group of patients, especially if you're able to achieve MRD negativity. The same is true for those patients with MRD positivity, right? That's why it says 0, right? These patients were once again allocated to a single transplant or a tandem transplant. It was the same. Even though they were able to achieve MRD negativity, there was no statistically significant difference with the use of transplant or a tandem transplant. So questioning the idea of a transplant in those patients. Now, we also have this other study, Predator MRD. This is a multi-center randomized open-label phase 2 study that is in Poland. This was published in the EHA a couple of weeks ago as well. And pretty much those patients that were observed after induction therapy, if they became MRD positive with a significant paraprotein relapse or significant clinical progression, they were allocated to either receive daratumumab after they became MRD positive or observation arm. Now, as we see here, the event-free survival probability is going to be higher for those patients in whom we preemptively started daratumumab when they were not having any symptoms of disease, but they were already becoming MRD positive. And what's important to mention in this study as well is that out of those patients, it was 24 patients, 12 to the DARA group and 12 to the observation arm. Those patients that were started on daratumumab, about 3/4 of those patients were able to re-achieve a status of MRD negativity. So this is what we talk about intensification of therapy. I don't want my patient to maybe become MRD positive because I know that eventually they will have symptoms, right? Or they will have a clinical relapse. The random trial is another study. This is probably going to be obsolete by the time that the results come back because this is using triplets and nowadays we're using mainly the quadruplets, but kind of have the same issue. Induction followed by transplant, followed by consolidation, and then observation and treat at MRD relapse or treat at symptomatic relapse based on IMWG criteria. Now, what's important to mention in this random trial, and these were just preliminary results, is that triplets work. It still had MRD negativity rate of 55%, probably not as good as quadruplet, but it still works. However, most of the patients that progressed during the first-line treatment were, again, those that had high-risk cytogenetics. I think what's important, what's going to give us a better answer, especially now that we're talking about bispecifics, is going to be the MASTER-2 trial. This is going to be induction with Dara-BRD, and it's also going to allocate patients based on MRD status, either negative or positive, with intensification in the arm of MRD negative, intensification with Dara-BRD for 3 cycles, followed by 13 cycles of Dara-Link maintenance, or transplant with Dara-Link maintenance. But for those patients that are MRD positive, we are seeing already that not only are we going to get a transplant, but we're also going to get bispecific with the teclistamab. So there are no results for this trial. We're enrolling for this one. We will hopefully see some results by next year. And in terms of my conclusions, I think again that MRD progression could indicate an underlying resistant malignant plasma cell population that may warrant aggressive management. Again, sustained MRD negativity is going to be better than a single-time measurement, and that for patients with MRD progression, we may be able to modify therapy, but this is especially true for our high-risk cytogenetic abnormalities. We have 2 or more, and that we have to educate our patient, right? Because this is not a thing that I'm going to start treatment on my patient. This is a shared decision-making, and that we have to educate our patients about the significance of MRD findings and the potential need for additional therapy. And with that, I'll take any questions.
Thank you, Peter. Can I ask you one question? Based on the MENAS trial, and so you were saying consolidation with transplant versus ACCREDITED, there was no difference between them. So how do you put into the equation? Are you doing transplant? How do you put the risk cytogenetics to the equation?
That's an excellent question, and I gotta say that once again, I'm from Cook County, so most of our patients were not able to send for a transplant for multiple other reasons. But I think that that's when you should have a conversation with your patient, because we are already giving quadruplets. We are able to achieve, good rates of MRD negativity and stringent or complete response. I think that for my standard risk patients, I would probably approach with observation. But our high risk cytogenetic abnormalities that have 2 or more, I think those are the ones that would probably benefit from transplant. But again, I mean, this trial didn't really show any significant impact when you did the transplant compared to chemotherapy alone. But yeah, that's probably my take-home point for that.
Patient population, it will be interesting to, because you mentioned a lot about MRD sustainability. So we do have just only 1 point of MRD. So I think I maybe want to wait and see if that MRD negativity is sustained and maybe those patients don't need the transplant. But I think maybe another time point of MRD might be important to make like a conclusion. Of course, the getting MRD is bone marrow, so patients might not like that, but maybe having another point to make sure it's sustained.
Correct. Again, the sustained MRD negativity is better. And I think you brought up a really good point. I think we have to do better and kind of put our efforts towards less invasive ways to try to obtain MRD. We are working on, we know that it's not the same, it's not as accurate as a bone marrow, but peripheral blood, flow cytometry, or next generation sequencing, by circulating tumor DNA. I think that's where our efforts should probably go to.
And the other point being that the follow-up is still less than 2 years, so there's no PFS, results yet, so I think, transplant still.
Yeah, it's definitely still, it's still on the table. These are premature data, of course. Thank you.
No, okay. Well, thank you guys so much for attending the session. It's the third session, so we're done with the summer series. The next 3 sessions will be in January, the last 3 Wednesdays of January, and we don't know if we're gonna be here. The dates are available, so we might be coming back here. We have another potential new venue that we're exploring, so we'll see where we land on that. You know the 3 topics. We have Gen Onc, which that's kind of vague, right? So it's lung or what have you. We always have breast, GU, and then we have hematologic malignancies. The dates are gonna fall on, we need to get our speakers and say, hey, when are you guys gonna sign up for? And then we'll go from there. So we'll be announcing that soon, hopefully. The post-test eval and certificate link will be sent out to those that signed in. So if you didn't sign in, please do. The QR code is at the registration desk. And for the faculty attendees and platinum and gold sponsors, we are having a reception. We have a couple bottles of wine, a red and a white, nice local beers, and we're just gonna hang out for a little bit and chill out and enjoy the end of the summer series.
You go on Michael Jackson, do you want to branch out?